Howdy, howdy, everyone. If you guys would like to start a massive MS nerd session during World MS Day, flame up the chat for me. Flame up the entire chat, and we will get rocking and rolling. That's awesome, guys. Wow. The village has spoken. I am so excited. Let me make sure that my cameras are on. Hey everybody, howdy, hello, hi. Aaron Boster here. Thank you for joining me with my crazy impromptu idea, jumping on a live stream just like I did yesterday, essentially unannounced. I am so appreciative that you guys put up with my erratic desire to go live and were willing to join me today. Let's just make sure that things are working. Does the sound all right, guys? Let me know in the chat if we're doing okay with the sound. I got dressed up for a reason. Let me know, is the sound okay, guys? All right, good. You're saying yes. You should be able to hear a little music in the background. All right, super duper. I love it. Yay! That's so exciting. So why am I dressed up? I'm dressed up because I'm doing a nerd session. And I wore my absolute nerdiest jacket. My team teases me when I put this jacket on. Oh, you said there's sound is great, no music. There should be very faint music in the background. So Laura, one of our amazing moderators, says that you're awful dressed up for a Memorial Day. Laura, it is Memorial Day, and my family's not getting together until later on. Truth be told, I'm not ready to buckle down and do a couple hours worth of office work that I need to do, but it's also World MS Day, and I had such an awesome time yesterday doing this impromptu nerd session that I decided I wanted to do it again today. And so I got dressed up in the spirit of being a nerd myself, and I was really excited to kind of share some content. I've got folks from Dubai. It's great to see you, my friend. Brandy Bryant's in the house. Same jacket at the office visit. Yeah, I do wear this nerd outfit sometimes. So let's kind of talk about what I have planned for you today. I have prepared a discussion looking at the MS clinical literature. And I'm going to use two clinical trials that I've prepared to share with you how I developed some of my thoughts and how I use the literature to influence them. So let's just put this together. Nerd session underway. Okay, all right. There's 108 of you that have got on. That's awesome. Thank you very much. It is Memorial Day today, and I want to remember Americans that fought for our country. I want to think about my grandfather, both my mom and my dads that fought in wars, and we're going to shift away from that content to do this discussion about MS. All right, so I do want to be respectful of that. All right, so sound stopped. You guys can hear okay? You guys can hear all right. It's making... All right, I'm going to assume that it's working. Yeah, absolutely. Thank you, vets. That's a fair thing to throw through. Okay, great. All right, so let's get started. And I'm going to record this because I'm probably going to use the session, at least the didactic portion, as a video in and of itself. So I'm going to roll the intro again, and then we're going to jump straight into it. Why? So that I can then post this later on YouTube for folks to watch in a different format. Here we go. Howdy, hello, hi, Aaron Boster here, coming to you on a live stream. It's Memorial Day. It's also World MS Day, and I'm all dressed up in my nerdiest of jackets because I'm going to do a nerd session with you right now. A nerd session surrounding an MS topic that I think is very, very important. And I'm going to show you how we use the medical literature to inform our decisions. All right, so let's jump into a discussion of two papers that I want to go over with you. This is the first paper. Now, this paper came out in Journal of Neurology, which is a very esteemed journal. It's a very high-end journal, and it's a relatively recent contribution. So you see up at the top, December 2020. Now, that's not a new paper. Right? Something that came out in December 2020 in my field is not considered new, but I think it's contemporary enough that it's relevant for this discussion. What's the topic? The title of the paper is Discontinuing DMTs, so stopping MS medicines, and people that are over 50 who have disease inactivity. Right? So this is a very hot topic today in May of 2022 as I make this video. What about people with MS who are over the age of 50 and are not having attacks? What would happen if we stopped DMTs in these patients? That was the question that they asked. And there you see the authors of the paper. And I'm going to be sharing the abstract with you. So, whoops, I'll tell you what I want to do is I want to change. All right, so stopping DMT after 50. So this is really the topic, and then let's start by going through the background of this paper. All right, and I'm using the abstract to help guide us. So the authors write that treatments may become redundant in older patients with MS. All right, so what does that mean? Well, these authors and other investigators are sometimes saying, hey, listen, as a human being gets older chronologically, their immune system can slow down, and the likelihood that someone has an attack or new MRI lesions decreases with chronologic age. So you're more likely to have attacks in your 20s than in your 60s. And so this leads some doctors to think about, well, maybe we don't need to give people medicines when they're older. Now, just to be clear, I think that's not okay. I actually really disagree with that decision. I do not recommend stopping MS medicines. In fact, this morning, so 4 hours ago, I put out a video talking about de-escalating, which to me makes a lot more sense than stopping. Okay, that stated, the authors here are bringing up that discussion, and they're saying, listen, maybe we don't need to be giving people over 50 MS medicines. And so what they did is they did an investigation to try to answer that question. And they said, all right, I'm going to look at people who are over 50, but also over 50 without disease activity. That's the group they're asking the question in. So stopping DMTs after 50, I should specify. Stopping DMT after 50 years old in stable or in inactive patients. Question mark. All right. Now, inactive. What does inactive mean? Well, so no attacks is no new spots is what they're talking about. And so I don't know if you can hear my dog is snoring under the table. So if you can, that's really funny. All right, now let's look at what they did. Okay, so first of all, so we're getting into the methods of the paper. This was not a clinical trial. Let's see if I can get my dog to stop snoring. River dog. If I can wake her up and then she doesn't snore. Thank you. So this was not a clinical trial. So in a clinical trial, you enroll patients into an investigation and then you study them or some fashion. This was not a clinical trial. This was looking at a registry. And registries are a really great way of answering a question like this. So in a registry, you can go and ask a question and then look through all the patients in the registry and then try to compare some things and come up with an answer. And that's what these authors did. Now, this registry is called the MS Lorraine Registry. It's Lorraine, France. And so you can see there in Alsace near Germany, this is the area that they were studying. That's where their clinic is. And so they went to this registry where they've monitored their MS patients. And they pulled patients out if they were over the age of 50 and if they had a relapsing disease course and if they had not had attacks for 3 years. So those were the criteria. So let's write that down. So first of all, they're pulling out 50-year-old relapsing MS, no attacks in, let's see, over or equal to 3 years. All right, this is the group that they were looking at. So if they found someone in their registry who met that criteria, they pulled them out to study. Then they separated them into two categories. People that had stayed on their medicine, and they called them stayers, and then people who had stopped their medicine, they called those stoppers. So had you stopped or stopped your medicine or not stopped your medicine? And those are the two different groups. And again, this wasn't a clinical trial. These are patients from their clinic that they were able to segregate because they were able to go back through this registry. Okay, so what were they trying to do? Well, they were trying to look at these outcomes. Number one, how long before you had an attack? So you have these people who are over 50 who have not had an attack in 3 years, and some have stopped their medicine, some have not stopped their medicine. Who's going to have their attack first? So the first person to have an attack. So first relapse. Time to first relapse. So did one group have a relapse in a month and the other group had relapses in 6 months, and is there a difference? The second thing they looked at is time to disability progression. So your EDSS we talked about on this channel before is a scale to measure neurological disability. And so if they look at the scale of disability, how quickly did one group get to disability versus the other? Okay? And then lastly, the occurrence of hitting EDSS 6. And that's really important. EDSS 6, so let's talk about that. EDSS 6 equals a cane to walk a soccer field. Okay, so if you need a cane to ambulate, then you have an EDSS 6. And so one of the things they were looking at is in these stoppers versus these stayers, who reached that neurological disability milestone of needing a cane. Okay, and the way that they did this was using propensity scores and multivariate analysis. And that's some really cool statistics that allow you to compare across groups. And I'm not going to talk about that too much right now, but I will talk about that a bit more when I talk about the next study. Okay, so we've set up what this study did. It looked at the question of should we stop people, or what happens when you stop people's medicine after the age of 50 who have not had MS attacks for 3 years. We segregate the stoppers and the starters, and then we look for these 3 outcome measures: time to first relapse, time to progression, and then time specifically to EDSS 6. Okay, so here are the results of the study. The first thing I want to point out is that a lot of people did they looked at a lot of folks. So there were 132 people who had stopped and 366 who had continued, right? So that's not a small number of people in this database, in this registry. And they followed them on average for 7 years. And I just want to make a comment about that. You can't do a clinical trial for 7 years. It's not possible. It's too expensive. There's no earthly way that a clinical trial could very easily follow that many people for that long. And so this is important information because you're basically not going to get it another way. Now, there's a question, Ben says, how do you determine the EDSS? I have some videos on the channel about EDSS. Quickly, it's determined based on a neurological examination. So you turn the neuro exam into a number between 1 and 10. All right, so looking at the results, there was no difference, no statistical difference between the stoppers and the starters regarding when they had their first relapse, that first line there. And to teach you a little tiny bit about statistics, a p-value, all right, so you see where it says p equals 0.61? A p-value is a way of saying, did the difference between the two groups occur just randomly, or did it occur not randomly because of a real statistical difference? And so the math cutoff for a p-value is 0.05, at least typically that's what we use. So p less than 0.05, this value is oftentimes considered statistically significant. And what that's kind of saying mathematically is this difference that we see between these two groups would only be explained by chance less than 5 out of 100 times. And so when you see a p-value less than that, that means that it's even less likely to occur. Well, here, this p-value is 0.6, so it's not remotely statistically significant. There's no difference between the stayers and the stoppers with regards to relapse rate. Didn't matter. Let's keep looking. Then they look at time to disability progression. Time to disability progression also was not statistically significant, right? And so when you look at that, if you just looked at those two things, it didn't make a lick of difference. And if we stop there, you would say, well, you know what, Aaron, maybe it doesn't matter if you continue on your disease-modifying therapy after the age of 50 if you haven't had attacks, because the people that stopped their DMT didn't go on to have attacks more frequently than the folks that stayed on. The people that stopped their DMT didn't have progression quicker than those that stayed on. So maybe it doesn't matter. Well, it does matter. Here's why it matters. If you look at the highlighted portion, the investigators found that if you stopped your disease-modifying therapy, you were much more likely to need a cane. Allow me to repeat. Amongst the people with MS, relapsing MS, who are at least the age of 50, who had not had an attack in at least 3 years, the ones that stopped were way more likely, in fact, 3.3 times more likely to end up needing a cane compared to those that didn't. And the p-value here is very, very statistically significant, 0.003. So that's a stark difference. So when someone says, well, I'm 50, I've had MS for however long, but I'm over the age of 50, and I haven't had an attack in 3 years, so maybe I don't need to keep taking these medicines. This is why I disagree. Here's an example of data where no, the person didn't have an attack, but they got worse. How did they get worse? Yeah, Jen, you're right. Wow. They got worse because they needed a cane. And you see that AHR. So AHR is the adjusted hazard ratio. So the adjusted hazard ratio is the proportion or the risk, and that adjusted hazard ratio is 3.3. So it's 3.3 times more likely. Very, very disturbing. All right. And so this is data that I think is really, really important. The other thing that I want to tell you, and this is really, really eerie, this paper looked at a lot of people that were taking first-line therapies. Right, so we're talking about shots. And imagine the impact on the disease with more efficacious medicines. So this is a really, really important discussion for me, because this is where this kind of data comes from. It doesn't come from clinical trials. And I wanted to kind of nerd out with you a little bit and see what you thought about this paper, and kind of share it with you. So let's keep this idea in mind, and let me take a couple questions before I talk about a second paper. And so I'm going to turn to the chat now and just kind of look through here. And see if there's any questions that you guys have. Some of you are kind of like in shock. Angela, our moderator, throws up a shock emoji. So Ben writes, at this stage of my life, I'm not willing to stop my DMT for a length of time to see if it will make a difference or not. Amen, my brother from another mother. So let's talk about Ben's comment a little bit. And let me switch around maybe just for a little bit, we'll do some Q&A in this format. So I agree with Ben. I don't have MS, but it's my life's work helping families impacted by MS live their best lives despite having this condition. And there's lots of ways that we can impact that. Exercise and diet, healthy living and meditation, all of these are really relevant. But the DMT is also really relevant, maybe even more so in some regards, regarding its impact on slowing the disease down. And so Ben says, well, I'm not in a position where I want to stop and see what happens. And I really feel that way. Because if you stop and then down the line, it turns out that nothing happened, well, great. But if you stop and down the line, you're worse, not great, and you can't get that back. And so I always think of staying on a DMT as an insurance policy against worsening. And this is a paper that explains that. So let's see if there's any other telling questions. So Mama Bear asks, do DMTs have an impact on brain volume? Yes, but not equally. So some of the medicines are not very good at slowing brain volume, and some are very good at slowing brain volume. So you want to ask your neurologist, hey, is my specific drug good at slowing brain volume? Jason Bell asks, so what happens when Medicare or insurance gets a hold of this paper? Well, if they got a hold of the paper, first of all, they would say it's not class 1 evidence. And so they would arguably poo-poo it. But if they looked at the paper, what they should do is they should use it as evidence to keep people on drugs. Now, the way that I would use this paper is if I was having a discussion with an insurance because they had denied someone a therapy, I would send them this paper and say, look, here's some evidence that coming off the drug's a bad idea. And we do things like that at the Boster Center for MS. Sometimes we have to write letters like that. Let's look for another question. So Laura writes, I'm 62. I was just diagnosed in the last year. Oh, I lost her question. I'm sorry, Laura. Here's a question, comment. Rachel, newly diagnosed, just shy of turning 50. Had these patients had the disease for years? And so I think on average they were followed for 7 years, and I don't have the paper pulled up to be able to answer that question. So Laura shares, I was diagnosed at age 54 by a young neuro in Columbus. Thankful I had treatment options. Okay, let's take a look at the second paper that I have planned for you guys, right? And then we'll take some questions about both papers. Now, this next study that I wanted to look at is an old study. And you see that it was put out in 2016. And why did I choose to use it? Well, a couple reasons. Number one, it's using my favorite MS registry, my favorite big MS database, MS Base. So you see there where it says at the bottom, MS Base Study Group. So the MS Base is an international registry where if you want to, as a clinician, if the doctor or a clinician wants to add in the patient's information voluntarily, then they can. And it's a really, really large register. I want to say, 74,000 patients. I don't think I made that number up. I think that's what I remember. And so you can use MS BASE to do really, really cool clinical investigations where you can ask questions that otherwise can't be asked. And so they do that really well. And so here's an example of that. And it was relevant to the topic that I wanted to talk to you guys about. So the title, first of all, let's look at the journal. The journal is a very good Journal of Neurology, Neurosurgery, and Psychiatry. And the authors are listed there. And you see those are the top 10 authors. And then all the rest of the folks that participate in the MS-based study group are given reference. And what's the title? Discontinuing DMTs after a prolonged relapse-free period. Right? So this is not looking at people over the age of 50 like the last paper. It's just looking within this database. If you've had a run with no relapses, what happens if you stop your medicine? So very similar discussion to the last paper, but using a different database. This is the MS BASE registry as opposed to the Lorraine one that we just looked at. Again, you really can't answer this question with a clinical trial. It needs to be answered in this kind of situation. So this makes a lot of sense. And so here's the background to this paper. And they're saying, and again, I want to point out, this is 2016, so these are absolutely first-line therapies. So these are therapies that I don't use in my clinical practice because they're not efficacious enough for my patients. This entire study is looking at those old-school first-line therapies. And so just keep that in mind as we look at the data, because maybe it would look even different if you were using modern high-efficacy paper study, like the injectables aside. Sorry, I'm not being very clear. This paper, 2016, is looking at injections, drugs that I don't use very much anymore. And I wonder if you redid this with a modern cohort looking at modern drugs, what we would see. All right, but keep in mind, this is looking 2016. And asking the question, if you stop medicines after you've had a good run of it, what happens? So you haven't had attacks in a while, let's stop your medicine and then see what occurs. The objective of the study was to compare time to first relapse, that's the same definition that we looked at the last paper, and time to disability progression. And again, they're going to look at two groups. They're going to look at the stoppers and the starters. And they're not looking at any particular age, just anybody that's in this giant database. And I highlighted propensity score matching. So I want to talk about what that means because it's really statistically neat. Propensity score matching. So I'll throw that up in the screen so that you can see that word. All right. So what does that mean? When you do a clinical trial and you're trying to compare two groups, and you're trying to see if one responds better than another, it's really important that the groups are very similar, if not exactly the same. Because if they're not similar, it can mess up the result. And let me give you an example. In a clinical trial, let's say a clinical trial, if you were to look at a drug, so you give these people the drug and these people don't get the drug, right? Two different groups. And let's pretend that the way that we segregated the groups is I picked. And I'd say, you go there, you go there, you go there, you go there. And I'm just choosing based on how I feel. I may introduce bias into those groups. Maybe I end up putting all of the men on one side and all the women on the other. Hey, Dad. Maybe I end up putting all the old people on one side and all the short people on one side and maybe all the people who are bald on one side. Maybe I segregate them in a weird way, which is biased. And that would mess up the result of the study. So the way that you avoid that in a clinical trial is you assign them to the different allocations randomly. If you flip a coin each time someone comes by, and based on the coin flip, then you're going to have a random group and a random group. And if you do it that way. And there's a couple old people on this group, then there's going to be a couple old people on that group just because of chance. If there's going to be a percentage of women in one group, there'll be a roughly the same percentage of women in the other group by chance. And this allows you to have two samples that you can compare. Here, they don't have a randomization. These are just people that entered the registry. And that would make it really difficult to do a comparison. Statistically, you can't. Hence the benefit of propensity score matching. What they do is they look in the database, all right, and they find a human who stayed on a medicine, a stayer. And that human has certain characteristics. I'll make it up that they're a guy, they're 30, they don't have any comorbid conditions, they've had MS for 10 years. Then they look through the whole database and they find another guy, 30, MS for 10 years, but they stopped their medicine. So they match the two humans for their baseline demographics. And you can create two groups. You can create a group of starters, people that stay on the drug, and a group of stoppers who are otherwise very, very similar because you build the two cohorts. So that's really cool statistics. And what it allows you to do is to answer questions like this in a statistically savvy fashion without doing an impossible clinical trial. So I just wanted to spend a moment and say that using this MS-based registry, they use propensity score matching. And the last study, the Lorraine registry, also used the same concept. And this is a very powerful clinical tool. So what did they do? Okay, so they included people from this MS-based registry if they met these criteria. They had to be older than 17, all right, so they're not looking at children. So any adult, 18 and up. They weren't allowed to have an attack for 5 years. So in the last study, it was 3 years. This is 5 years. So here's an adult who has not had an attack in 5 years at the time that they had stopped the drug. And that we at least had to follow them for another 3 years. So here's someone who had not had an attack for 5 years at the time they stopped their drug. And then we had to follow them for at least another 3 years to see what happens when you stop your drug. Okay, they weren't allowed to restart their drug after the discontinuation, all right, because you didn't want someone coming off and then jumping right back on. So they had to be off for at least a period of several months. And these were the people that they pulled. These were the stoppers. So that's how they define stoppers. So they went to this MS base registry, and which is huge, 74,000 people, I think, and they pulled people that met that criteria. All right, and that's how they built the group for stoppers. Then they looked for the stayers, and the stayers had to have no relapses in 5 years. All right, and then they were propensity matched to match the stoppers. They had to be the same age, the same sex, and the same level of disability. They had to have MS for the same amount of time and the same amount of time on treatment. And so through propensity matching, they were able to make these two groups identical so that they could then compare. The thing they compared, the folks that had stopped the DMT and then followed for 3 years versus the people that had stayed on the DMT and then followed for 3 years. Okay, so that's how they set up their discussion. What did they look at? Here's what they looked at. They looked at relapse, they looked at disability, and they wanted to see, do the people that stopped have disability faster or more frequent, or do they have attacks more frequent than the people that didn't stop? And they're comparing those two groups. And then they talk about the statistical ways that they did that. So let's take a look at the results. So time to first relapse was the first thing they looked at. And the time to first relapse was compared. They found 485 folks that met that criteria that had stopped their drug. And they compared near 500 stoppers to near 900 stayers. So the first thing I want to point out is this is not a small assessment. Very, very large numbers. So that helps us feel more confident that it's not just a by chance outcome. And the hazard ratio, which is the risk, is 1, which is not really a risk. So it's basically the same likelihood, one versus the other. And you see the p-value is not statistically significant, right? The p-value is 0.5. And so there's no statistical difference when you follow someone who stopped the drug and then follow them for 3 years than those that stayed on, as it relates to time to first relapse. All right, what else did they see? When they looked at disability progression, it was not the same, it was different. So here, confirmed disability progression was statistically significantly shorter amongst the stoppers. And it was about 50% more. So if you stopped and then they followed you for 3 years, you were about 50% more likely to progress in disability. Allow me to repeat. You take a group of people, all right, anyone 18 and older, and you have some of them stop the medicine and some of them not stop the medicine. By the way, all the people had not had an attack in 5 years. And what you find is the folks that stop are not more likely to have an attack. But you find that the folks that stop, sorry, there's airplanes. The folks that stop have a 50% more likelihood of progressing in their disability. This is really, really disconcerting. And let's see how they kind of summarize the results. Patients who stop an injectable, a first line, what I consider low efficacy medicine, after a long period of being relapse-free, don't have an increased risk of relapses, but they have a higher risk of disability progression. Mind blown. So what this is teaching us, and I think Wade said it really well, is scary. What it's teaching us is these 2 different registries. All right, one from Lorraine, France. One is the MS base, which is this huge registry. One looking at a couple hundred people, one looking at near 1,000 people. These are really, really large. That if you stop your MS medicine, and we're looking at what I consider to be low efficacy medicines, that it's not necessarily likely that you're going to have an increased risk of attacks, but you are going to have an increased risk of needing a cane and progressing. So, this is the kind of information that informs my clinical decisions, why I am interested, for example, in continuing people on medicines even when they're older. And this is why I don't agree with stopping medicines when you reach a certain age. Now, if you're listening to this live stream, thank you so much for jumping on. I would love for you to share in the chat your thoughts on this format. Do you like these nerd sessions? If so, let me know because I'll do more of them. If you're watching this in the replay, definitely same thing. Let me know if you would like to see more in a kind of format like this. Leave a comment and then I'll read them. Now, the other thing I want to share with you, I want to read this. I was diagnosed at 40. Sorry, excuse me. The other thing I want to share with you is I put out a video this morning. All right, so if you haven't yet seen this video that I put out this morning, it's actually relevant to what I'm talking about because I don't believe in discontinuation for the reasons I just showed you, but I do believe in de-escalation. And so if you haven't seen the video yet, check that out. My name's Aaron Boster. I hope that you have an amazing Memorial Day. I also hope that you have an amazing World MS Day. And I really appreciate you jumping online to participate in this nerd session. So until my next video or my next live stream or the next time I see you at the Boster Center for MS, this is Aaron Boster saying be safe and take care, guys. Have a great day.